It's now 25 years and 10 months since I carried out the first metal-on-metal hip resurfacing of the modern era. So I thought it would be appropriate for me to give you an update on hip resurfacing. The very first batch of hip resurfacings carried out in 1991 were most interesting, and there have been some really rewarding results in patients from that era. I show you this x-ray of a young woman called Katie Ellis, and she had her surgery age 21, and shown here is her 25-year follow-up x-ray. She has done really well and is delighted with the results of her surgery. This is a photograph of her taken a few years ago with her 2 children, and they of course were born after she had her metal hip resurfacing. The oldest boy has just obtained his university degree, and the youngest boy has just started at university this year. So the lessons from the first 3 years of hip resurfacing was that first, the optimum fixation for hip resurfacing was an uncemented acetabular component and a cemented femoral component. And second, having done a number of different surgical approaches, the posterior approach gives best hip function. The question remains, how long will these metal-on-metal hip resurfacings last? And we do have some people who can give us the answer. This lady had her metal-on-metal total hip replacement 46 years ago by my predecessor, the late Rodney Sneath, and I carried out her right hip resurfacing 20 years ago. Both her hips are absolutely perfect. Here you can see her entertaining her dogs in the garden, and she carries on without any problems with her hips. Then we moved on to the hybrid fixed coronary resurfacings that I designed, and these were uncemented cups and cemented femoral components. And the single heat treated devices show a 96% implant survival at 10 years, but unfortunately the double heat treated devices did much worse and show only an 86% implant survival at 10 years. So the lessons from year 4 to year 6 were that the cast metallurgy is best for metal-on-metal bearings, and we also discovered that cup positioning was very important to avoid edge wear of the cup and a metal reaction. Then came the BHR era, starting 19 and a half years ago, and there are the 19-year survival graphs for men and women with a minimum 2-year follow-up. So there's 2,277 men and 617 women. And you can see that the men do better than the women, and the women are just above the nice threshold for an acceptable result. When we look a bit more detail at the men, then you can see that age has no effect on the outcome in men. So all men of different ages have around a 2% failure rate at 19 years, which is a very acceptable result. The story, however, is different for women. Young women do really well, and women over the age of 50 do not do nearly so well, and they are borderline acceptable, judging by the NICE threshold. There are some fantastic outcomes in those young women, and here is one, Sian Williams, and she's the World Masters doubles badminton champion. You can see her pre- and 1-year post-op x-rays there. And she got, of course, small components, being a woman. So that's some photographs of her in competition. And here's a video of her warming up for a badminton match. She is a very impressive athlete. So both on the group results and individual patient results, these women under the age of 50 do really well with a BHR. However, in the women 50 plus years, they do not do nearly so well. And you can see all the steps on that graph, and all those steps represent failures. So let's look now at why women 50 plus years fail. The first most important cause of failure is bearing failure. And there are 15 bearing failures out of these 494 women. Femoral failure is the next most important problem. And the shortest follow-up, 2 patients had spontaneous femoral neck fractures. These were in the first 6 months after surgery. Then the next 5 patients had collapse of the femoral head. And then the patient, just over 15 years post-op, she had a fall and suffered a traumatic fracture of her femoral neck when she fell downstairs. Then there's 3 infections, which is unfortunate but acceptable for a group of 449 patients. Let's look at femoral failure, and this is the BHR, and the green represents cement, and on the left you can see the component part way inserted onto the bone, and unfortunately the BHR sidewall jam onto the bone and trap the cement, and then as the component is impacted into place, cement is driven into the bone, and the more cement that's in the component, the more filling of the femoral head that occurs, and the more osteopenic the femoral head is, the more chance there is of high pressure cementation causing excess cement filling of the femoral head. So this is highly undesirable, but may be related to osteopenia and also the design of the component. So we have changed the design of that component in the polymotion femoral component, and there you can see on the left it is partially inserted, the green again representing the cement, and you can see that there is controlled egress for cement as the component is inserted. So you will not get this extremely high pressure filling of the femoral head. When the component is fully seated, then there is a 1 millimeter cement mantle between the inside of the femoral component and the outside of the femoral head. So we regard that as optimum cementing for a hip resurfacing femoral component. Just to point out, there was no case of loosening of the femoral component in any of my BHRs, and all of those, of course, had cemented femoral components. But this overfilling of cement and resulting femoral head collapse from death of bone is an important cause of failure. All the components of the polymotion heads are the same, in that they allow controlled egress of cement as the component is inserted, and they've all got narrower and shorter stems than the BHR. When we look at metal reactions, this is a typical case, and this lady had her component inserted in good position, as you can see on the left, but at 4 years post-op, the x-ray didn't look good. She's got disappearance of her teardrop, disappearance of the lateral edge of the acetabulum, erosion of the medial and lateral femoral neck. So this is osteolysis. No loosening, but osteolysis. There's no increase in her metal ions, but on CT scanning, you can see arrowed is a fluid collection at the front of her hip. All the angles are great. Cup inclination, 31 degrees, cup antiversion, 20 degrees. These are exactly what we would want. She hasn't got excess femoral neck antiversion, 26 degrees, combined antiversion, 46 degrees. So we can't blame patient anatomy or component positioning for her failure. This is explant retrieval analysis, and the femoral head shows a wear zone in the top of the femoral head. And when you look on the cup on the right, then the wear patch is in the middle of the cup. This is not edge wear. This is where we all hope that the wear zone would be. The problem, she's got nickel sensitivity. That's the only thing we could find in this lady, and she kept getting episodes of pain in her hip when she exercised, and eventually I had to revise her hip. There were 15 metal reactions in this group of women age 50 plus. Much too much. So the lessons from the last 19 and a half years is that metal-on-metal bearings are not ideal for women age 50 plus. And metal sensitivity is a very real entity, particularly in the older women. Now, why in the older women? We're not entirely sure. Whether women eventually sensitize themselves to metal by wearing jewelry for a prolonged number of years, it's really not known. But metal sensitivity and metal reactions are a big deal. Now, how can we get out of this metal-on-metal problem? This is a standard total hip replacement cup, and that has a shell with a porous coating on the outside of it and a cross-linked polyethylene liner. Now, the shell is 4 millimeters thick, and the cross-linked polyethylene liner is a minimum 3 millimeters thick. And the combination of those two is far too thick for a hip resurfacing. We really want 3 millimeters minimum of cross-linked polyethylene. And we've been able to do that with 6 years of laboratory endeavor and prototype manufacturing. We've got a 3 millimeter minimum thickness cup and the porous coating directly on the outside of the polyethylene. So compared to the situation in total hip replacement on the left, we have missed out the metal shell, and that saves a lot of bone, and that allows us minimum thickness of 3 millimeters of cross-linked polyethylene, and the same coating is applied directly to the cup. Has this been tried before? Well, it has. The buccal papas cup had a polyethylene thickness of 4 millimeters. The buccal papas was conventional polyethylene, and there was a high failure rate from wear of the conventional polyethylene. The shell thickness at the edge was 2 millimeters, and the shell thickness at the pole was 3 millimeters. But the outer diameter to inner diameter difference is 12 millimeters. And contrast that with both the BHR and the Polymotion cup, and they have an outer diameter to inner diameter difference of 6 millimeters. So that means if you put in this buccal papas type device, you're going to lose 6 more millimeters thickness of bone. Now that bone can go from either the femoral head or the cup, or both. But there's a limit to how much you can downsize the femoral head, and that is governed by the width of the femoral neck, because you can't go too small with the femoral component, otherwise you will notch the femoral neck. So typically when you have a component that's too thick, then over-reaming of the acetabulum is necessary. Surgeons who operate on young people with hip resurfacing absolutely hate to have to over-ream the acetabulum, because that acetabulum is required in the future should a revision to a conventional total hip replacement be required. So Jim Pritchett has modified this buccal papas device, and he has replaced the conventional polyethylene liner with a cross-linked polyethylene liner, but the same thickness constraints still pertain. This is an example of an over-reamed acetabulum with a conventional shell and cross-linked polyethylene hip resurfacing. Not good. I want to show you some examples of the Polymotion cup in real-life patients. So this patient had a failure of his ASR with a pseudotumor 6 years down the line. Now, those 6 years he really loved. He was extremely active, and he wanted treatment for his pain and pseudotumor, but he would not let me revise his resurfacing to a conventional total hip replacement. And instead, he allowed me to keep the femoral component of his ASR, remove the ASR cup, and replace it with a custom Polymotion cup. And the middle picture shows that, and the right-hand picture shows you the situation 1 year after surgery. He has done really well, and 6 months ago he cycled around France in aid of the Soldiers' Charity. This is a woman, a ballet dancer and now a ballet teacher with metal sensitivity. And I've done a custom Polymotion cup and head on her, and you can see the 2 months and 1 year post-op films. She has done extremely well, and she's behaving just like all the patients I have with metal resurfacing. This is a new implant, and of course we are investigating this thoroughly, and here you can see RSA x-rays 1 year after her surgery. The fixation looks great, and the wear of the crosslink polyethylene cup looks minimal. My feeling from having seen small numbers of patients out to a year is that metal on crosslink polyethylene hip resurfacing is going to be the future, but that remains to be proven. However, having waited for over a year in a small number of patients, I will be doing a lot more Polymotion resurfacing implants during 2017. So I'm going to let Elaine describe to you her postoperative recovery and what she's up to at the 1+ year stage postoperatively.
My name's Elaine Williams-Fuller. I had my op done July 2015. The recovery's been really good. It's gone really well. At the beginning I had to remind myself to do all my exercises and do lots of walking, which was definitely the key and helped me tremendously. 3 months was a turning point, and certainly 5 months was a turning point. I started doing my ballet class that I go to at about 3 months, which wouldn't recommend to everyone, but having been a dancer previously, I was aware of movement within the hip and took it very gently, kept the leg very low, kept the rotations small, but that certainly did help. That was like a progression on from the exercises that the McMinn Centre had given me. So that began to build, and certainly by 5 months I had to remind myself not to overdo it, if anything, because there was no pain, so I had to just keep reminding myself to take it easy and follow the instructions from the McMinn Centre. Pre-op I was becoming more and more restricted. First of all month by month, and then week by week, and then daily. It was just totally restricted, and I was counting down the days till the McMinn Centre rang me to say, we've got a date for you. I was finding it really hard. Post-op, it's amazing. There's no pain. I don't even know it's there. Normal life carries on as normal. It's excellent. I'm so pleased with the results. My expectations with my new hip, I'm just so pleased with the results. I've got my life back. Totally. I can teach my own classes, I can demonstrate properly, I can do my Saturday ballet class. I'm now free to jump a year on, which is fantastic. I'm just living normal life. I can walk, I can swim, I don't notice my hip at all anymore. The results are amazing. I'm forever grateful for what Mr McMinn and his team have done for me. No pain whatsoever. There's no adaptations in my life at all since the op. Life has just got better and better, it's got stronger. Apparently my bone density is really good, which I'm so pleased at, and that's from doing all the exercises. And life is just so good. I'm so pleased that I've had it. No pain, no restricted movement. It's excellent, brilliant. The impact on my life now compared to post-op or pre-op. Pre-op was bad for about 2.5 years. I struggled to teach my classes by the end, certainly doing my film and TV work, being on my feet all day. The pain within my hip standing was just so bad. Limping constantly, lower back pain, referred pain in the other hip. Now that's all gone. I don't even think twice what I'm about to do in the day. I just get up and get on with my life, which is what life should be all about. The new hip is like my old hip was before it became arthritic. It's just perfect. It moves, it doesn't hurt, it doesn't grind. I don't have any pain standing. It's just amazing. There's no pain, there's no referred pain elsewhere was as bad at times as the actual hip pain. The backache went immediately after I'd had the op. So did the other hip pain that was referred from the arthritic hip. Just completely pain-free. I can't feel as such my new implant at all. It just feels completely normal. It's I just don't know it's there. It just feels normal. No pain, don't notice it's there. Don't notice it's there getting out of bed, out of a car, no other pain. My advice to anyone struggling with hip pain and having the advice that they need to have a hip operation is to obviously do their research. I did my research. I found the McMinn Centre. The McMinn Centre does metal testing, which for me, I just think is amazing and excellent. I had no idea I was allergic to metals at all. Was shocked to find out I was allergic to metals. Hence, I had to wait for the special new polyethylene cup. And that was the only one that was suitable for me. It was a new device. My advice to anyone is to do their research. The team are excellent. Their physiotherapy department, excellent. All the information they give out. And my advice to anyone is just, it's very scary, but to take the plunge and go and see and have the operation and get your new life back. My advice to anyone who says they're going to wait till they're older, they're going to put it off for 1 year or 2 years till they're older, or 5 years, is don't put it off. It just gets worse. The pain gets worse. Your life that you're able to live and the things you're able to do is more and more restrictive. Pain dominates every single minute and second of your day, from getting out of bed in the morning, driving your car, the whole day's activities, to your sleep pattern at night. My advice is just don't wait. Have it now, get your new life back, become pain-free, and you just won't look back. And it's just the best thing that ever happened to me, certainly. I have absolutely no regrets that I've had it done at all. It's amazing. I can't stop smiling. I can't thank the McMinn Centre enough and Mr McMinn for giving me my life back.